Good evening, sir.
Hello.
Good evening, sir.
Hello. Yeah. Good evening. Can you end your screen sharing? I will give you option.
I think, sir, you are doing the screen sharing or?
No. Hello.
Yes, sir.
Yeah. Can you end your presentation? Hello.
Sir, you're going.
Yeah.
Echoing.
Hello. Good evening, sir. Good evening.
Yes, sir. Good evening, sir. How are you, sir?
Yes, sir. I'm fine. Can you end your presentation so that I'll give you opportunity? Can you stop
Manu,
sharing?
I'll tell him, sir. Manu, presentations end karo. Yes.
Yes,
That's
sir.
fine.
Okay. Thank you. So that now this thing is going on now, means the introduction to our society is going on. Then I'll give you again
Okay.
opportunity. Okay.
Okay, sir. मनु ध्यान
Yeah.
रखना इस चीज का. Okay? मनु अनम्यूट करो अपने आप को.
No problem, sir. That's okay.
Yes, sir. Sure, sir. I will take care of this,
Just
sir.
keep
Yeah.
this
I
in
will
mind.
give you opportunity.
Once-
I will properly introduce sir, and then I'll give you opportunity. Okay.
Sure, sir. Thank you so much, sir.
Okay. Yeah. Thank you.
Good evening, everyone. Can you hear me?
Good evening, sir.
Can you hear me?
Yes, sir.
Yes, sir.
You're audible, sir.
Okay. So can you hear me now again?
Yes, sir. You're audible.
Okay. Thank you so much for joining today's program, and welcome to everyone who is on air. And we are again back with another important show, that is webinar Web J Club. So stylistically we can say Web J Club, and this is the one of its kind. First time we are conducting this program. I would like to welcome Dr. Prithpal Singh sir. He kindly accepted our invitation to join and own this first Web J Club. So thank you so much, sir, for volunteering and taking this initiative to be part of our program. And I welcome you and Dr. Manu Arya. So he will be the first presenter. I think we are creating the history in the Medical Pharmacologist Society, books. And this is going on air in YouTube again. Getting recorded. Yeah, so let me say again. So welcome everyone. Welcome to the Medical Pharmacology Society first WebJ Journal Club. So I'd like to put on record that it is the first of its kind program that is conducted by Medical Pharmacology Society. I would like to thank Prithpal Singh sir and Dr. Manu Arya for owning this opportunity and volunteering and taking this opportunity forward and creating the history in the books of Medical Pharmacology Society. So I'm saying this because recording was switched off. That's why I want to record it again. So thank you so much, sir, for taking this opportunity and coming forward for guiding our postgraduates and young and enthusiastic researchers and the most important future medical pharmacologists. And with this, I would like to present a little bit about our society and then release the book, and then I will hand over the mic to our today's speaker. Let me just open this. Yeah, can you see the presentation?
Yes, sir.
Yeah, thank you. Thank you, sir. So Medical Pharmacology Society is founded in 1960 under the Karnataka Society Registration Act. And our mission is to provide a platform for MD pharmacologists for innovating themselves to serve the community better. Our vision is to build the MD pharmacologist profession as the most respected and most innovative one, with amalgamation of all the scientific and technological advancements. And then our objectives, you can see that now we have been doing a lot of work related to quality education and then employment support, training and development of our workforce, and trying to, provide these skills through various workshops. We are yet to start industry internships. Let us work on it. And then specialty labs. Yes, we would like to work on this also. Pharmacogenomics is one of the specialty where we have conducted many workshops and webinars we are conducting, and hope that we will come up with some more activities. Biostatistics program, that is the one of the certificate courses under, already first batch is completing. Then multidisciplinary approach. We would like to collaborate with various life science, associations, and provide the best platform where mutual cooperation, mutual collaboration happens. And we'd like to collaborate with government for conducting, some of the funded, research activities. Collaborate with international universities and associations, and establish the pharmacovigilance nodal centers. And also, we would like to start with the journals and newsletters. But we have already started various publication activities, which I will be presenting in a very short while. Then we would like to, develop the various centers as research centers by providing the technical support and SOP support and others, whatever that is required. And also would like to establish the ethics committees or central ethics review board or support board, so that people are able to secure the grants and whatever required for that we would like to do. And then develop the review boards where we can monitor the safety of the ongoing trials. And then we would like to collaborate with the pharmaceutical companies and help their research work also. And then develop new molecules if possible over a period of time. If we would like to establish a center of excellence through all your support. We would like to develop our own research lab. So we hope that all these happens over a period of time. Okay, so again, like we would like to develop the MD pharmacologists in such a way that they own their own business also. For that, if you remember, we conducted CEO conclave recently, and that really, thrown a lot of light on how an MD pharmacologist can become an entrepreneur. And then what are the memberships available? Life memberships, professional membership is available. Those who have completed already MD, they can become life member, professional. Then students also, MD pharmacology students also, they can also secure the life membership by paying the full fee. And then it is considered as the life member student category, but it will be converted into full professional life membership after they complete their MD. And then student members, they can also pay limited amount and then limited category, validity of 3 years only. So that kind of, please, Manu, can you stop the, yeah. So I was saying that, student memberships also, we offer. And then some of the honorary members, those who have contributed to the professional development of various MD pharmacologists and also MPS society, we would like to offer them also some of the honorary membership. And then some of the institutions or industries, they would like to collaborate with us. We would like to give the honorary industry memberships also. So these are some of the opportunities, and contact details are there. All of you are already having. And now I would like to, before this, I would like to say that anyone who is interested, please get in touch with me or the email provided. We would like to support the induction of more number of MPS members. Books released. So we have released already 4 books. Recently, we released one book called Crucial Pharmacology Trends Volume 3. And this book is available in, Flipkart and then Amazon, and more than 155 countries, this book is released, and it is available now. And it is, available in a very nominal fee. So you can see here. So you can please go through it. And then the contents are like, if you see the contents, we are going by paper 1, paper 2, paper 3, paper 4. So the contents of this volume can, highlight, it is highlighted that all these are the paper one related chapters. Okay, so the topics, you can see that, all these topics are taken from various question papers that are set by various universities, especially for the postgraduates. So, don't miss an opportunity to buy this, so that, you will get the first-hand information coming from all the professionals. If you see who are the authors of these chapters, most of them are the, professors, associate professors, assistant professors, working in various institutions and guided by their professor and heads. So in this way, we are providing a, opportunity, or learning opportunity for all the interested PG students and the professionals to get these books and, own these books, and they can easily have easy reference book for them. So in this way, I would like to encourage everyone to, go through the Amazon, Flipkart, Notion Press website, and many other websites also. They are posting our, many our books. So please go through it, and you can, own your book by just purchasing, and with a few clicks. You don't need to go to any shop. All of them are available on the, on the air. So you can go to these bookshops or online bookshops, and easily you can buy. And similarly, volume 2 and volume 3, volume 1 and volume 3, volume 2 are also available. Okay, so I think you are already aware if you are attending webinars since long, so you already get the prompts. So, but there is one more book called Clinical Trial Management, which is also available. So Notion Press version is also available, and Amazon version is also available. So please feel free to go to these websites and then, get an opportunity to buy and use them for your betterment. So with this, I would like to now introduce our chairperson. I would like to introduce our chairperson. So, as I told you, that we have a very nice scholarly person, Dr. Prithpa Singh Matreja is currently working as Vice Principal, Professor and Head, Department of Pharmacology, Tirthankar Mahavir Medical College and Research Center, Moradabad, okay, UP. So I have a very good relationship with him, by saying that he's a very nice professional, highly motivated, and I think his age, I don't agree that he is a senior, because he goes down to the students' minds and students' level, and he brings the programs in such a way that students are very happy to participate, and I'm very enthusiastic, I'm very much enthused through your energy. Even though you are in Moradabad, I feel like you are there next to my door. That's the kind of energy you have, and that is shown in your publications. There are so many publications, 125 publications with national and international journals. And then he's also, authored a textbook of pharmacology and lecture notes in pharmacology. And then is contributor of, chapters to diabetes and essentials of psychiatry book. And then he owns research grants on multiple short-term projects funded by Tuberculosis Association of India and ICMR, and actively involved in clinical trials at PMCH, VSMCH, and TMMMC, And then he's an academic leader. I can say he's called as the guest speaker in many associations, nationally and internationally, on various chapters like rational drug use, clinical research, medical education, and like topics. And he's a life member of almost all the good reputed societies like MPS, and so ISRPT, many more you can see here. Then he is the founder member of EMSA, and then he has the editorial role of editorial board member of clinical researcher, education in medicine journal, then American Journal of Health Research, clinical medicine journal, like he is associate editor of Journal of Medical Education and Ethics. And he is having so many, activities, including NU and Animal Ethics Committee membership and membership of CRC. Then again, Chitkara University Ethics Committee member. So like this, we are very happy to see your enthusiasm, and I'm sure your energy is spreading throughout India, and you are energizing everyone. And I'm sure, I am following you, and I told you also, very happy that, I replicated some of your teaching techniques here by making our students to participate in making the models, especially on drug dosage forms and others. So I'm sure, we can learn from each other, and we can improve ourselves day to day. So with this, I would like to again thank Dr. Pitwalsin sir and also Dr. Manu Arya for taking this opportunity and being with us. We are very much energized. We would like to. We look forward for your energetic presentation. Thank you so much, sir. Now I'll stop here. I request you to take over and do the honor of introducing the speaker and going ahead with the presentation. So that's presentation. Thank you, sir.
Thank you so much, sir, for the kind words that you have showered your so many appreciations toward me. I am really humbled and honored for all the appreciation that has been given. Uh, it is always a two-way learning process, and always I learn something from you, you learn something from me, and not only us, but even from the students, we tend to learn a lot. So that is how things go, and each time we perform an activity, it tends to there is further always a scope of improvement further beyond what we have been talking about. And you never know how an improvement comes in. With a small input, we can have large amount of improvement. And I really appreciate your effort of starting a journal club, first of its kind, obviously. I have not seen it, and we had this thing in our mind, but somehow uh, you took the initiative. It's a great effort from your side, and really thankful to you for taking this particular lead on this. And now, before I start with the journal club, and I tell my PG resident, the third year PG resident, Dr. Manu Arya, to go ahead with the presentation and start sharing the screen. I think I can tell him to start sharing the screen. Dr. Manu, if you could start sharing the screen, and then maybe I'll suggest few things about what to go ahead. Yeah, that will be fine. So, well, as we have already, already told you, and Sarah has already told you that this is the first one of its kind uh, thing that has been happened in overall. We have not seen it recently. And now, when we talk about a journal club, what is important is that we first select an article, and then we go with that article. We try to analyze that article, and when we talk about a article that has already been published, so it would be very awkward for us, or very no, we will not be in a good position if we say that we will criticize an article that has been published in a journal of repute. So it would not be a critical appraisal of a journal. It would more of be a basically a process of how we can go ahead with a journal club presentation. So all the authors who ever publish their research articles, they put up a lot of effort, and they tend to look into many things together, and they are looking into many aspects of the research article. They are publishing it, and obviously the research article is being published in a journal of repute. So taking due note of that, we have not deliberately hidden the name of the journal, the title of the article, even the authors, so that in any place we have definitely we have hidden the uh, the context whereby an article can be highlighted that this is this particular article. We try to do that. And what we are focusing on out here is the process. Maybe we might not be 100% accurate. It, as already said, it is a learning process. So we learn something from you and you learn something from us. It is always a two-way process. So maybe we can, with your inputs, we can get into many more modalities of how we can go ahead with this. And it is always possible that there will be some inputs, but obviously I'm already highlighting that all these inputs I would require for the process of how a journal club is presented. You want to add something to a journal club being presented at your institute, you are free to do that. And you are always free to share with us that whatever you feel is appropriate. So hopefully I believe, or I hope that I do justice to whatever duty has been assigned to me. And what I'll be doing out here is I'll be introducing my PG resident, Dr. Manu Arya. He's a third year PG resident at our institute, and he has completed his MBBS from Rohilkhand Medical College, Bareilly, and he has worked as an emergency medical officer for a sufficient amount of time at Sir Gangaram Hospital, New Delhi. So he has a lot of clinical experience and he has been with me for the last 2 years. So I discussed this matter in the department and he readily took the initiative that, okay, sir, I'll go ahead with the presentation. So I hope we tend to learn something from this presentation. Over to you, Manu, for the presentation, and then we'll have a discussion once your presentation is complete. Manu, you can start your presentation.
Sure, sir. First of all, I would like to thank you, sir, for giving me a golden opportunity to do a presentation in Medical Pharmacologist Society, sir. So, and I would like to thank the Medical Pharmacologist Society for this golden opportunity to me. So today, first of all, a very good evening to uh, all of the senior faculties and all the fellows. So today, my topic is treatment outcomes with certolizumab pegol and adalimumab in patients with rheumatoid arthritis. So myself, Dr. Manu Arya, I'm a third year PGJR. My guide is Dr. Preetpal Singh Matreja, sir, who is a professor, head of the department of pharmacology in Tirthankar Mahavir Medical College and Research Center. So, starting with the warning, the article is the viewpoint of the author and the way he has interpreted it. I just intend to present it with author's viewpoint and the way he has written in the journal. We would discuss from our viewpoint what was done and what can be done in our settings. By no means this is any derogatory remark for authors. So, author is using the following abbreviations uh, in this presentation. So, RA it stands for rheumatoid arthritis. RF is rheumatoid factor. ACPA is anti-certolinated protein antibody. TNFI is tumor necrosis factor inhibitors. CZP is certolizumab pegol. ADA stands for adalimumab. MTX stands for methotrexate. And DES28 is disease activity score for 28 joint count. DES28 CRP is disease activity score using C reactive protein. DES28 ESR is disease activity score using erythrocyte sedimentation rate. CDAI is clinical disease activity index. SDAI is simplified disease activity index. HAQ-DI is health assessment questionnaire disability index. And LDA is low disease activity. And NRI is non-responders imputation. OCR observed case, AUC area under the curve, drug concentration, IRB is institutional review board, ICA GCP is International Council for Harmonization, good clinical practice, and Q2W is every 2 weeks. So moving ahead, uh, starting with the introduction part, rheumatoid factor. Rheumatoid factor is an autoantibody that targets the crystallizable fragment region of IgG. It is commonly found in patients with rheumatoid arthritis. Rheumatoid factor can exist in different immunoglobulin isotypes like IgM, IgA, IgG. But IgM-RF is the most clinically measured. Around 60 to 80% of rheumatoid arthritis patients have detectable IgM-RF. Clinical significance of high RF level. High RF level are linked with poor prognosis in rheumatoid arthritis associated with more aggressive and destructive diseases. higher disease activity, increased cardiovascular risk, and greater radiographic progression. Now, TNF inhibitors, common biologic treatments for rheumatoid arthritis include certolizumab pegol, adalimumab, etanercept, golimumab, and infliximab. All TNF inhibitors target TNF alpha but differ structurally. Certolizumab pegol is unique because it lacks an Fc fragment while others contain it. Now, impact of rheumatoid factors on TNF inhibitor response. Rheumatoid factor positivity, especially high rheumatoid factor levels, has been associated with a reduced response to TNF inhibitors. Preliminary evidence suggests this poor response may be linked to the Fc fragment present in some TNF inhibitors. Now, patients with high rheumatoid factor may respond better to Fc-free TNF inhibitors like certolizumab pegol compared with Fc-containing TNF inhibitors. In pooled analysis, certolizumab pegol showed similar efficacy across different RF level, unlike Fc-containing TNF inhibitors. Now, a study hypothesis: high rheumatoid factor level may lead to faster clearance and reduced efficacy of Fc-containing TNF inhibitors. Fc-free TNF inhibitors may maintain drug levels and efficacy in such patients. Aim of this study is to compare efficacy and drug concentrations of certolizumab pegol versus adalimumab in rheumatoid arthritis patient with different RF levels using a post-hoc analysis of phase 4 head-to-head trial. So it found that patients with high RF clear Fc containing drug like adalimumab faster, so they respond less well. And certolizumab, which has no Fc portion, is not affected and works better in these patients. So high RF patients may benefit more from certolizumab. Now, patients and method. Now, the study design and the patient. It is a phase 4 trial of 104 week, randomized, single blind, double blind until week 12, head-to-head superiority trial. Population adults more than equal to 18 years with active rheumatoid arthritis with a score DAS28, erythrocyte sedimentation rate more than 3.4. And this DAS28 score has following parameters like more than 5.5 is high disease activity, between 3.2 to 5.1 shows moderate disease activity, and between 2.6 to 3.1 shows low disease activity, and less than 2.6 shows remission, and more than equal to 4 swelling joints, elevated HSCRP level more than equal to 10 milligrams per liter, or ESR more than equal to 20 mm of H, and despite more than equal to 12 weeks methotrexate therapy. Now, biologic DMARD naive rheumatoid factor or ACPA positive, that is anti-cetylated protein antibody, and a stable methotrexate dose more than equal to 28 days before the baseline. Now, this is a consort diagram which shows that uh, total eligible rheumatoid arthritis patients are further randomized into two groups. Uh, First groups is certolizumab pegol and methotrexate therapy, which has around 453 patients, and another randomization with adalimumab plus methotrexate therapy, which has around 454 patients. So these are stratifying according to the rheumatoid factor level to see how rheumatoid factor influence the effectiveness of certolizumab versus adalimumab. Now, there is a baseline RF level, which is 204. So, in the group of certolizumab, pegol, and methotrexate, out of 453, 334 were there in the low RF group, which is less than equal to 204, whereas 119 are with the high RF group, which is more than 204. And in adalimumab plus methotrexate group, around 347 were with the low RF group and 107 were with the high RF group. Moving ahead, now discussing the interventions dosing in the phase 4 trial. So certolizumab, pegol, and methotrexate group. Initially, there was loading dose of 400 milligrams at week 0, 2, and 4, then 200 milligrams every 2 weeks plus methotrexate. And in adalimumab plus methotrexate group, 40 milligram every 2 weeks plus methotrexate. And there was no loading dose. To maintain blinding in the first 12 weeks, patients receiving the adalimumab also got placebo injections at week 0, 2, and 4, so that it looked similar to the certolizumab pegol, which had extra injections during loading. Now, about ethical approval. The phase 4 trial was approved by the National regional ethics committees or international review board, and conducting according to ICH good clinical practice guidelines, declaration of Helsinki and local laws. Informed consent was obtained from all the patients, and for this post hoc analysis, no new approval was needed since the data were anonymized and aggregated only. Now, discussing the outcomes, drug plasma concentration with AUC, disease activity measures with DAS28 CRP scoring and DAS28 ESR scoring, and clinical disease activity index, which has a range of 0 to 76. Less than equal to 2.8 shows the remission, less than equal to 10 shows low, and moderate is between 10 to 22, and high is above 22. Now, SDI is scoring, which is a score range of 0 to 86. Cutoffs are remission with less than equal to 3.3. Low is less than equal to 11, and moderate is between 11 to 26, and high is more than 26. And HAQ-DI scoring with a score range of 0 to 3. 0 shows no disability, 1 shows mild to moderate disability, 2 shows moderate to severe disability, and 3 shows severe disability. Now, the proportions of achieving the low disease activity or Boolean remission. Boolean remissions is patient must meet all 4 criteria at the same time, like tender joint count should be less than equal to 1, swollen joint should be less than equal to 1, CRP level should be less than equal to 1, and uh, all the 4 levels should be less than equal to 1. Now, number needed to treat for low disease activity. Sensitivity analysis excluding patients with high anti-drug antibody levels more than 58th percentile and stratifying by ACPA level. Analysis used full data to week 12, and from week 12 only valid treated patients, non-responders, switch drug, area under curve used for drug levels, results reported as observed cases. With Boolean remission by NRI, p-values were nominal. Now, moving ahead towards the results part. So this table represents the baseline demographic and patient characteristics, which is stratified by RF level at the baseline. So tables has a two portion. The left side we can see patients with low RF level, that's quartile 3, and right side we can see patient with high RF level. So all the parameters are like in the basically with low RF level, basically patients were young, the disease duration was shorter as compared to the high RF level, low disease activity were there, and less steroid use were there. In the high RF patients, right side patients were mostly older, there was longer disease duration and higher disease activity, and steroid use were more, and there were ACPA level were high. So group were otherwise well balanced between both sertolizumab and adalimumab arms. So comparisons are fair. Now discussing these parameters. So this figure compares the drug plasma concentrations of the sertolizumab pegol, which is FC-free TNF inhibitors, and adalimumab, which is FC containing inhibitors. So data are shown over 104 weeks for 2 years, and patients are divided into two groups based on baseline RF level. So dotted line here showing the low RF patients, and solid line showing here is high RF patients. So the left panel here shows that initially from 0 to 6 week there is a initial spike, and this spike is due to the initial loading dose of sertolizumab pegol, which was 400 milligrams at weeks 0, 2, and 4. And after the 12 weeks, we can see the plasma level stabilize around 23 to 27 μg per ml, and there is no big difference between the low RF and high RF patients, and error bar standard deviation overlap. Concentrations are regardless of RF level. So this panel shows that RF level do not affect the sertolizumab concentrations, whereas in adalimumab, here y-axis shows the adalimumab plasma concentration, and x-axis shows the weeks from 0 to 104. Similarly, dotted line represent the low RF level in adalimumab, and here dark line represent the sertolizumab. So as we can see here, there is a gradual rise until week 12, and ADA reaches steady state plasma concentration, and after week 12, levels remain stable, but there is a clear separation appears So low RF patients, the mean is around 6.2, and in high RF, there is approximately 4.8. So error bar shows that high RF patients consistently have lower ADA drug levels across time, and high RF patients have reduced ADA concentration, suggesting faster clearance of ADA in presence of rheumatoid factor. Now, ahead, now this here, the axis represent the weeks and Y axis represent the DAS28 CRP mean scoring. As we can see here that the left panel, which is a low medium RF less than equal to 204. Both certolizumab pegol, which is orange line showing that, and blue line represent the adalimumab, reduces disease activity equally. At week 104, the mean DS scoring CRP was about 2.5, as we can see in both the groups. So there is no significant difference between certolizumab pegol. So in patients with low RF, which is less than equal to 204, both drugs are equally effective, as we can see throughout 104 week. Whereas in the patients with high RF, which is more than 204, we can see that mean DS28 CRP fell to about 2.5 in certolizumab pegol and 2.9 in adalimumab treated patient. So the difference was statistically significant. Error bar shows less overlapping, confirmed reliability of differences. And in high RF patient, the certolizumab pegol achieved better disease control as compared to adalimumab. Now, moving ahead, basically the here, as we can see the left panel with low RF, here we can see the DES28 CRP low disease activity scoring on the y-axis of the proportion of patients, and axis represent the weeks. So here we can see that 64.8% achieve low disease activity at week 104, and 65.1 achieved low disease activity at week 104 in adalimumab. So both certolizumab, pegol, and adalimumab performed equally well. There is no significant difference over the duration of 104 weeks. So in low RF patients, either drugs works fine. So whereas here you can see with high RF, certolizumab pegol 65.7% achieved the low disease activity at week 104, whereas adalimumab is only 48.3% achieved LDA, low disease activity. So relative improvement is there. So certolizumab showed a 36% higher likelihood of achieving the low disease activity compared to that of adalimumab throughout 104 weeks. So this proves that in high RF patient, here certolizumab pegol is the winner, clearly superior to adalimumab for achieving the low disease activity index. So here we can see that both certolizumab pegol and adalimumab causes a rapid fall in clinical disease activity index mean during the first 12 weeks here. Then from week 12 onwards, there is a stable and overlapping curves throughout. And at week 104, the certolizumab has a mean CDAI scoring of 7.3, whereas adalimumab has 7.6. So there is no meaningful difference between the two. So in low RF patients, both drugs are equally effective. Whereas here with IRF patients, certolizumab pegol has maintained a CDI mean scoring of 7.2 till 104 week, and adalimumab has CDAI mean scoring of 9.1. So there is a difference is small, but favor certolizumab pegol. So here the certolizumab pegol shows a superior effect as compared to the adalimumab in decreasing the clinical disease activity index mean. So CDP has a more mean CDAI, showing better control of disease activity as compared to adalimumab till 104 week here. So here we can see uh, proportion of patients achieving clinical disease activity index with low disease activity. Here we can see this left panel with low RF level. Certolizumab pegol with the yellow orange line shows 75.9% reach clinical disease activity, lower disease activity index at week 104, and whereas adalimumab has shown 74.9%. So curve overlaps almost completely throughout the 104 weeks. So in low RF patient, both certolizumab pegol and adalimumab, both drugs works equally well. where here in the right side, we can see that certolizumab pegol has achieved around 78.6% CDAI LDA level at week 104, whereas adalimumab has achieved 68.3% CDI low disease activity. So the gap between the line is consistent. So more certolizumab patient stayed in low disease activity till 104. So we can see that in high RF patient, which is more than 204, certolizumab pegol again is superior with approximately 10% in achieving more low disease activity till 104 weeks. Now, here we can see a comparison with disease activity score 28 CRP mean. So here we can see both drugs reduce DAS 28 CRP significantly from the baseline to 104 weeks in both ACPA groups. There is a steep fall initially from 0 to 26 week, as we can see. Then there is a plateau around the 2.5 to 2.6 DAS CRP mean scoring, so showing the low disease activity. Here also sotorasib pegol is a superior over adalimumab. And this right panel also, we can see that both the drugs have equal effect. So DS28 CRP mean scoring is equal in both the cases. So now moving ahead. Here we can see the y-axis represent the DS28 ESR mean scoring. So here we can see initially certolizumab pegol is having a mean of DS ESR mean of 3, and whereas the adalimumab has 3.2 DS 28 ESR scoring mean till 104. So here also certolizumab has proved to be more effective as compared to adalimumab, whereas the right side also certolizumab pegol, the mean is around 3, and adalimumab it is around 3.2 till 104 week. So here also certolizumab pegol is superior till 104 week. Now, discussing the result that with low RF patients, which is less than equal to 204, certolizumab pegol and adalimumab work equally well as a similar DS28 CRP ESR scoring, CDAI, SDAI, remission, and HAQ DI scoring. Whereas in high RF patients with more than 204, certolizumab is superior to adalimumab. There is a better disease control, lower DS28 CRP and SR scoring, and CDA, AI, and SDAI index both are lower, and more patients achieve low disease activity and remission with certolizumab pegol. And adalimumab drug concentrations were lower in high RF patients, but certolizumab level remain stable, and rheumatoid factors seem to accelerate ADA clearance, FC binding, but not certolizumab pegol because it is FC free. Now, drug concentration, adalimumab AUC is lower in high RF versus low RF patients from week 12 onwards, and certolizumab pegol area under curve is similar regardless of rheumatoid factor level. So efficacy, we can see in low RF patient, the DAS 28 CRP and LDA rates were similar for certolizumab pegol and adalimumab at week 104. Whereas in high RF patient, certolizumab had significantly lower DAS 28 CRP scoring and higher low disease activity rates and better CDI SDI outcomes at week 104. So this sensitivity analysis confirmed results after excluding high anti-drug antibody patients and when stratifying by ACPA level. Now, this post hoc analysis of phase 4 trial directly compared certolizumab pegol and adalimumab in rheumatoid arthritis patient stratified by rheumatoid factor levels. So in high RF patients, certolizumab showed better clinical outcomes, and adalimumab had lower drug concentrations and reduced efficacy consistent with RF binding to its FC fragment and faster clearance. And in low RF patients, both certolizumab pegol and adalimumab were equally effective. As discussed earlier, sensitivity analysis, excluding patients with anti-drug antibodies, findings were unchanged. Stratification by anti-sertolin protein antibody levels with no differences between certolizumab pegol and adalimumab suggests effect is specific to RF, not ACPA or anti-drug antibodies. And prior studies also showed lower ADA drug survival and efficacy in high RF patients. And this analysis strengthens evidence using head-to-head trial study. Now, this study has a few limitations that only one FC containing TNF inhibitors like adalimumab was compared with certolizumab pegol. Other FC containing TNF inhibitors like etanercept, golimumab, infliximab were not included. And being a post hoc analysis, the original phase 4 trial was not specifically designed or powered to detect differences based on RF level subgroups. Sample size in the high RF subgroup was limited, which may reduce the statistical power. Baseline smoking status data were unavailable, although smoking is a known factor for affecting the rheumatoid arthritis outcomes. And results may not be generalizable to real world population outside trial inclusion exclusion criteria. Other factors influencing TNF inhibitors clearance or immunogenicity may not have been fully accounted for. Now, conclusion is that high rheumatoid factor patients represent a subgroup of rheumatoid arthritis with poor prognosis. And in such patient, adalimumab concentrations and responses were reduced, while certolizumab pegol efficacy and concentration remained stable. So the difference is linked to the FC fragment of adalimumab, which is absent in certolizumab pegol. So key findings are respond to TNF inhibitors in high RF and rheumatoid arthritis is influenced by the presence or absence of FC fragment. So this supports using FC-free TNF inhibitors like certolizumab pegol in patients with high rheumatoid factor levels. Now, Consort 2025, incorrect and missing items. Here we can see that major consort deviations were there, like incomplete structured abstract were there, which lacks setting, sample size justification, randomization details, and harms. Trial design was not fully reported. There was no clear labeling of trial as parallel, 1:1 randomized design, missing details on blinding after 12 weeks. There is randomization was not reported. So no description of sequence generation, allocation, concealment, or implementers were there. Incomplete methods reporting were there. No sample size calculation seen. No adherence, compliance description was there. No statement on outcome changes. So post hoc nature not clearly emphasized. Subgroups analysis performed but not pre-specified in the protocol. Statistical methods not fully explained. No tests were described. Missing details on handling missing data beyond OC and NRI. Participant flow and recruitment. There was no consort flow diagram was not provided. Recruitment dates and trial settings like cities and countries was not stated. Outcomes and analysis issues were there, like primary versus secondary outcomes from the original phase 4 not clearly restated. Use of arbitrary RF quartile cutoff was there. No explanation for effect of switching at week 12 on analysis was seen. Adverse events reporting were missing. Harms was not included despite consort requirement. Now, few positive and negative points. Positive points were that clear scientific rationally linking of RF rheumatoid factor to FC mediated clearance were there. 104 head-to-head randomized design is there. There is a good description of intervention and switching protocol. Multiple rheumatoid arthritis outcome measures like DS28, CDAI, SDI, and HAQ-DI scoring were parameters were checked. Sensitivity analysis for anti-drug antibodies and anti-sertolin protein antibody were there. Negative points were post-hoc design and which shows the higher risk of bias. No multiplicity correction for repeated subgroup testing was seen. Missing randomization blinded details, which increase the risk of bias. Harms, safety not reported in this analysis. Several authors from the funding pharmaceutical company and smoking status, which is an important parameters for rheumatoid arthritis confounder, was not available. So funding pharma company sponsored the study, writing support funded. So these were the detailed parameters shown by the author. Thank you so much for
Thank
giving
you,
me the.
Manu, for your
Thank you, sir.
elaborate description of this particular study. You did a good effort by putting up all the essential parameters that were there. You even highlighted the results. Now, there are certain queries which I would like to ask from you out here based upon what you have found out in the study. So you mentioned about blinding.
Yes,
So could you highlight what did they mention in the study? What type of blinding was mentioned in the study? You
sir,
said
double
you
blinding was,
double blinding up till what week?
sir, basically, sir, only, sir, until week 12,
Okay,
sir, patients and investigator were blinded.
okay,
And sir, after which, sir, it became single blinded, sir, because, sir, investigator remained blinded, sir. Sir, and
okay.
patients,
So
sir,
this
could
is something
identify the.
that is deviating from what we normally follow. When we say a single blinded study, we say that single blinded study is normally the patient doesn't know about the drug out here, but out
Yes.
here they blinded the investigator. Maybe they might have, did they specify why did they blind the investigator in this particular part?
Sir, 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 after 12 weeks, sir, it becomes single blind because, sir, investigator remained blinded, sir,
No,
and
but
patient could identify.
was there any mention why investigator was blinded in this particular study?
Uh,
Did you find anything written in the manuscript?
yes, sir. Sir, basically, sir, here, sir, sir, investigator, sir, to prevent, sir, assessment bias, sir.
Okay, okay,
Yes,
fine.
sir, because, sir, in basically rheumatoid, in this type of study, sir, where rheumatoid arthritis is there, sir, outcomes like, sir, which I showed, sir, disease activity 28
Hmm.
index and CDI and SDI are clinically assessed. And, sir,
Okay.
sir, if the investigator knows which treatment the patient is receiving, so,
Mhm.
sir, so, sir, by keeping the investigator blinded, sir, sir, joints count remained, sir, unbiased, sir.
Okay, fine. That's fine. That's absolutely fine. I believe that is good point in the study. Now, there was one more thing that you mentioned that the people who received sertolizumab, they had a loading dose of 0 at 0 week, 2 week, and 4 weeks,
Yes,
whereas
sir.
there was no loading dose given for adalimumab. So, did they specify why? What was the reason that they gave a loading dose out here and no loading dose for the adalimumab group?
Yes, sir. Sir, basically, sir, initial spike was seen with the sir, loading
No,
dose of
that is
400.
that is there. But did they mention what is the rationale why they are giving a loading dose of certolizumab?
Yes, sir. Sir, basically, sir, sir, certolizumab, sir, basically, sir, patients saw one group, sir, that's why receiving, sir, extra dosing, sir,
What
early in the
was the
spike,
reason
sir.
for that? Because I believe there was something that is I didn't find it in this study, but something that you mentioned in the literature
Sir,
there.
to maintain the blinding, sir, during the first
No,
12
no, no, no,
weeks.
no, no, not for that purpose. What we are talking about is that there was a loading dose given for certolizumab. What is the rationale for giving a loading dose?
Sir, one more thing. While discussing, can we point out the slide so
Okay,
that,
yes, sir,
yeah,
sure, sir,
that will
sure.
also help the, listeners to,
Okay, so
understand,
yes, sir, we can
get
do
it.
that. We can
That's
do that.
okay. Yes.
Manu, can you go back to the slides,
Yes, sir.
please? Further higher up, further higher up, higher up in the method intervention part. In the
Yes, sir.
intervention part, the
Yes, sir.
intervention slide, yes. So you could, if you could put on the PowerPoint presentation out here, slideshow.
Yes, sir.
Yeah. So like here out, you have mentioned that there was a loading dose of 400 milligram that is given at week 0, 2, and 4. What was
Yes, sir.
the reason that you believe, or you found it out in this particular article, or maybe you found out in the literature that you searched that certolizumab is being given in a loading dose, whereas the adalimumab is not being given in a loading dose?
Sir, basically loading dose, sir, is given to achieve, sir, therapeutic drug concentration in the blood.
Okay.
And, sir, here, sir, it has large molecular size and long half-life,
Mhm.
sir. And, sir, without a loading dose,
Okay.
sir, it takes many weeks to reach a steady state concentration, sir.
Okay. And so maybe this is one of the drawbacks for this. Then that means that this might be a drawback for a certolizumab possible.
Sir, might be, sir, because of faster onset of action and, sir, uh, better
Okay.
disease control, sir. Early disease control, basically, sir.
Okay. Then there was another thing that you mentioned. If you go to the consort diagram,
Yes, sir.
to the consort diagram, you said the next one. Yes, the consort, the methodology
Yes, sir.
part where you were talking about previously, previous slide,
Yes,
Yes.
sir.
the previous slide, the previous one,
Yes,
the
sir.
previous one, the previous one. Yes, this one.
Yes, sir.
So what is the next one? The next one, where you have made a consort diagram.
Yes, sir. This is.
So, what is the uh, reason that they have selected this 204 as a criteria for the rheumatoid factor count? Any specific reason for it?
Sir, here, sir, matlab, sir, sir, because, sir, third quartile, it represents the third quartile value of, sir, RF levels. Sir,
Okay.
sir, though they have divided into two parts, sir. Less than equal to
Uh-huh.
204 and more than 204, sir. So,
Okay,
so,
that's fine.
sir, 204 basically, sir, was the, sir, 75th percentile of RF level in the study population, sir.
Okay. And what was the rationale that they gave that why did they go for certolizumab over the other TNF inhibitors?
Sir, because, sir, certolizumab pegol is the only FC free crystallable fragments are absent in case of certolizumab pegol. So, sir,
Uh-huh.
sir, if FC fragments are absent, so, sir, the RF basically FC fragments are attached to the rheumatoid factor. So, sir, in certolizumab
Okay.
pegol case, sir, they are not attaching to the RF fragment. So that's why, sir, the
Okay.
drug is prolonged inside the body, and, sir, whereas in other without RF, with FC fragments, sir, excretion is faster because it is attaching
Maybe if you
FC
can
is
go to
attaching
that
to the RF.
particular, maybe if you can go to that graph or that figure which shows the AUC when you have this RF of 204 and where you are showing that the RF factor is contributing to the low. Yes, this one. So, so could you interpret this? Why is there a deviation in this particular part? You see that there is a low level of drug. If you go to the your right panel, the blue one,
Yes, sir.
what you see out here is that patients, the mean concentration is in those who have a lesser RF factor value. They have a value of 6.2, whereas the other people, the more than third quartile part, they have a RF factor of 204. So
Yes, sir.
is this related to this FC fragment?
Yes, sir. Here, sir,
Is this
yes, sir.
yes?
Sir, because, sir, adalimumab lacks the FC, sir, has the FC fragment. So, sir, the excretion here, sir, is more as compared to the certolizumab pegol, sir, and faster, sir,
Okay.
as there is a,
Okay.
sir, gap between the two lines, sir, dotted and the,
Okay.
sir, straight line, sir. So,
Okay.
suggesting, sir, faster clearance of ADA, sir, in presence of high RF, sir.
Okay, fine. So maybe that is why that they are suggesting that certolizumab is a better drug as compared to adalimumab, you know?
Yes, sir.
Okay,
Yes, sir.
so now if we can go back, we can go back to a few of the previous slides where we were talking about the methodology part. The methodology part, yes. So let's have some discussion on this particular, the methodology one, previous one, previous one, previous,
So this.
the previous one. Yeah. So any, what are the mention of the inclusion criteria? What was the inclusion criteria that they took for the study?
Sir, inclusion criteria is, sir, sir, adults more than equal to 18 years, sir, they took, sir, and, sir,
Hmm.
established, sir, diagnosis if patients are having established diagnosis of rheumatoid arthritis as per standard
Hmm.
criteria, sir, they have taken, sir, and, sir, they have taken the active disease, sir, at screening and baseline, sir. Sir, they have
Okay.
taken, like, if patient is
Any
having
other?
a, sorry, sir.
Go ahead, please.
So if patient having a
Go ahead. What you are?
TS28 ESR scoring of more than 3.2, so they have taken them. patients having more than equal to 4 swollen joints, 28 joint count, and sir, elevated acute phase reactant like HS-CRP more than equal to 10 milligrams per liter, and sir, ESR more than equal to 28 mm per hour they are taken. Sir, even methotrexate requirements, sir, for more than equal to 12 weeks, sir, prior to the screening. And sir, there is a stable methotrexate dose of for more than equal to 28 days, sir, before the baseline. And sir, they have taken,
So that
sir,
means the inclusion criteria that they included was all adults who were more than 18 years of
yes,
age
sir.
had
Yes,
an active rheumatoid arthritis disease that
yes,
was
sir.
not being controlled with
Yes, sir.
12 weeks of methotrexate therapy. The active
Yes,
disease
sir.
that they classified was disease activity score of 28 of ESR 3.2, four swollen
Yes, sir.
joints, and this. And they also included patients who had not taken any biologically active
DMA.
ARD. They were not to this, whether these patients were RF or ACPA positive and or depending upon, and they must have taken 28 days methotrexate therapy prior to this. So this was the
Yes, sir.
inclusion criteria that they took in this particular study.
Yes, sir.
है ना?
Yes, sir.
And what about they also mentioned something about the sensitivity analysis. What is the reason that they went for a sensitivity analysis in this particular? Maybe if you go to the next slide and we have this sensitivity analysis out here in the next slide, move ahead. Move ahead, next one. They even talked about some sensitivity analysis. We have
Yes, sir.
already discussed this one.
Yes, sir. Yes, sir.
Okay, so before now out here in the previous slide, we'll talk about sensitivity analysis because we are going, if we go one by one in the previous slide, slide number 11, the previous
Yes, sir.
slide.
Yes, sir.
I cannot get the previous slide at this moment. Yes. So yes, this one. So they said that got an approval from the Regional Ethics Committee and Institutional Review Board. They conducted it according to the ICH GCP guidelines and Declaration of Helsinki and all those things. Written informed consent was taken. And then they are mentioning a post hoc analysis that no new approval was needed. So could you just highlight what this particular aspect is all about?
Sir, I mean, sir, about the
The last
data.
point for the post hoc analysis, no new approval was needed since the data was anonymized and aggregated only. So at one place they are mentioning that they took the approval of ethics committee, and then the second place they are mentioning. So did they arbitrarily divide the treatment into two particular groups? That is why they are mentioning this.
Yes, sir, they have divided into two groups, sir. Sir, so
Okay.
basically,
So that
sir,
is
all patients are, sir, basically, sir, personal identifiers like, sir, name, address, hospital ID, sir, they have, sir,
so
they
they
might
took a 12
care
week
about the patient
cutoff.
privacy, sir.
No, they took a, I believe what I went through this article, so I saw that they took a 12-week cutoff. And after a 12-week cutoff, they said now beyond 12 week, it is a phase 4 study, so anyone can take it. And then they went for that switching of the drug. I believe you mentioned that
Yes,
also, switching of the
yes,
drug.
sir.
If the patient was not responding, you could switch the person to the other drug. So, but they did not. What is that mentioned is that they did not analyze those patients. है
Yes,
ना?
sir.
That
Yes, sir.
was that was mentioned. Now coming to the next slide, if you could go to the next slide, we could have a word on this also. They said something about sensitivity analysis. So
Yes, sir.
what is this? What is the reason? Why did they go for this sensitivity analysis? And why did they stratify this? What do you think could be the reason that they did this?
Sir, to eliminate the confounders, sir. Sir, particularly anti-drug
Okay.
antibodies and ACPA level, sir, to confirm that the reduced this ADA efficacy in high RF patients were due to, sir, rheumatoid factor, sir, which is interacting with the FC fragment, sir, and sir, not because of the other factors, sir, immunologic factors, sir. To proof of the finding were, sir, only robust to rheumatoid factors, sir.
Okay. So now coming to this particular aspect, now I would like to, just because we have already discussed everything, what is the key take-home message that you got from this article?
Sir, key take-home message is, sir, that sir, sotorasib pegol, sir, is more effective in, sir, in controlling the rheumatoid arthritis, sir, as compared to adalimumab, sir, due to his, sir, FC free fragments, sir. And sir, in rheumatoid arthritis patients, sir, with high rheumatoid factor levels like sir more than 204 sir. Adalimumab has shown sir reduced drug concentration overall 104 week in the results sir, and poor clinical response sir, due to FC fragments. And sir, so Satolizumab is always in the results part, sir, as FC free is there. So sir, it has a stable level and superior efficacy, sir. So sir, and high rheumatoid factor, sir, reduces AD efficacy, but not Satolizumab Pegol. And sir, which sir, it works better, sir, in controlling rheumatoid arthritis more as
So
compared to
the
Adalimumab, sir.
I think the key take-home message from what we get from this study is that this particular certolizumab has an FC fragment that is there. It is free from this FC fragment, and this FC
Yes, sir.
fragment binds to that rheumatoid factor and is cleared from the body at an early point of time as
Yes, sir.
compared to the drug which does not have an FC fragment. है ना?
Yes, sir. Yes, sir.
And for a patient who is over the third quartile, that is at a rheumatoid factor of 204, you have these patients, they have a better response with certolizumab. So we are targeting a selective group of patients out here. Now,
Yes, sir.
one of the key question or one of the key areas that I would like you to address is, now supposedly I want to replicate this study at a setup in India.
Yes, sir.
So according to you, what could be the challenges and what could be the benefits?
Sir, sir, first of all, challenge are, sir, the drug is very costly, sir, and sir, can't be afford with the Indian society, sir.
Okay.
And sir,
And what
as
about
this is a 104 week study, sir. Follow-up, sir, are very difficult to get, sir.
okay.
And sir, so financial challenges are there, sir. Sir, ethical and regulatory challenges are there, sir. So
I don't think there will be any ethical and regulatory challenge in India because India, I believe, is at par with all the other countries. So we'll not have any regulatory or ethical challenges because most of our ethical committees will approve this particular study. But what I definitely I believe that obviously the cost of this particular drug, that is one of the major areas of concern. And maybe what if we try to implement, if you go back to the inclusion criteria, there we mentioned one thing that we need patients who are biologic DMARDs, naive patients.
yes, sir.
I think that selected group of population getting it in India would be of a big task out here because almost all the drugs, all the drugs that are available, they are available over the counter. So anyone can procure them. So that is one of the major challenges, obviously. And uh, then there is another thing is obviously you told about the
Follow-ups.
follow-up. A 2-year follow-up is a quite a big time, and I don't believe because of frequent changing of doctors out here in India, we don't get this much. And we don't have I believe our country should work on a centralized data pool where all the patients, maybe all the patients linked are linked. Obviously the government is working on this and we are working on this ABA ID. So maybe we don't know, around 5 years, 10 years down the line, we might have uh, a good availability of this particular trial being conducted in India. And now, what was the important thing that you learned from this study? Any
Sir,
procedural method or maybe anything interpretation that you could learn from this particular study?
sir, basically, sir, I got to know about, sir, the efficacy of controlling rheumatoid arthritis with the drug, sir, how fast and how efficacious it is in controlling it. And sir, the importance about the sir, sensitivity analysis, I got to know, and sir, because multiple sensitivity analysis, sir, parameters were shown here, and sir, and I understand the mechanisms, sir, which were based on the clinical outcomes, sir, basically, and
Okay.
sir, and sir, it also told upon the importance, sir, of about the RF core trials, sir, rheumatoid factor core trials, and then, sir, how this with the help of this sensitivity analysis parameters, sir, how powerful is the study, sir, with this, and sir,
Okay.
uh, about the
Okay,
mechanism
Manu,
of
thank you.
action of.
Mhm. Okay, Manu, thank you so much for your insight into this particular study and your inputs. So I believe now we hand over the baton to Shivamurthy sir for further proceedings.
Thank you
Yeah.
so much, sir, for the golden opportunity. Thank you, sir.
Yeah, it was really great, sir. I think it was very nicely presented and also nicely discussed. And the question answer session was really good, and really helped us to, again dig into the details of the paper. And I'm sure, like as I understand that rheumatoid arthritis is a very common disease. Recently, like you can see that, if you go to this orthopedic department or medicine department, you will see a lot of cases with rheumatoid arthritis, and even my mother is taking this methotrexate. And it's a silently damaging the joints, and it is affecting so many patients. But it's a very nice, research article. You can see that, researchers have put a lot of efforts, and like Professor, you really pointed out very nicely regarding the design of the trial. I think if I understand that, like as you rightly said, phase 4 trial generally it is done using the population who are already
Yes, sir.
on the respective medication.
Yes, sir. Yes, sir.
That's why most probably they have a reverse method of applying the single blinding. Here they are
Yes, sir.
blinding the
That's correct,
investigators,
sir.
not the patients, because
Mhm.
patients already know that what
Yeah.
medications they are taking. See, this is something, which we all should take home. Message, what you rightly identified.
I think, sir, this study design was somewhat unique that instead of patient being blinded, it was
Yeah.
the investigator who was blinded so that
Yes.
he does not
Correct.
interfere with the disease activity index. He does not
Yes.
try to manipulate those disease activity index because then we
Yeah.
try to, because if we look into this study, pharmaceutical company sponsored study, so
Yes.
there's always the possibility of a bias that comes in, okay, this particular drug is a new drug, it will be better.
Yeah.
So I
Yeah.
think that is a good unique point this study has given us. And
Yeah.
obviously this method of single blinding can also be applied to all the
Yes.
studies in near
Yes.
future.
Yes. 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 And also one more thing, what you pointed out is related to the subgrouping based on the RF levels. So
Yes,
I
sir.
think that shows the dynamic design of the trial.
Yes, sir.
Most probably after conducting the trial, maybe
Mhm.
that's why they have said that post hoc analysis they don't require any ethics committee approval or something like that.
Yes, sir.
Most
That's
probably
correct. That's correct.
this
That's
is
correct.
an additional publication what they are trying to point out, that RF levels
Mhm.
less than 2.4, 204, and more than 2.204, how they are
Yes, sir.
reacting to this. Most probably they would like to target the drug to that particular population. So in that way, they can gain a mileage in for like positioning their product in the market. So that may be
Yes, that's
the
correct. That's
one of the
correct, sir.
strategy companies may adopt. And
Yes,
then,
sir.
yeah, it's a definitely, like, you can see that 2 years following the patient is not a small thing. And most, they have managed almost, I think, 800 patients, if I'm correct. 300.
Yes, it's 800. 453 in one group,
Totally,
454 in the other group.
yeah, it's a multinational big trial. So definitely it's a nice one. Thank you so much for taking up this. And we all are better. I think before 1 hour before we were little bit less intelligent, and now we are little bit more intelligent than what we were earlier. I think this is what we wanted to achieve. I hope all the participants are benefited out of these efforts. I request everyone to, the recorded session is available. Suppose if you have missed some portion of it, and please go back to the recording and hear repeatedly, and because now we have done the climax also. We have started both are there. Initial part and the climax part, both question answer, everything is there. And now if you again hear, most probably you will learn better. The students, I suggest that everyone to take this opportunity again, go back and again put your own things, because we are intelligent to some extent, not to the core everything. We cannot judge everything in one go, or we cannot our intelligence may not be so good that we are able to find out everything. I think being a sponsored trial, advantage is that they have the complete resources and they can spend in getting whatever all they want. That's the advantage of sponsored trials. And the drawback is that they can analyze the results according to their requirement. So that's the one.
Yes, that's correct.
That's the one drawback of it.
So I think that goes back to a study of the rofecoxib,
Yeah,
the Vioxx trial, the infamous trial that was there. So it goes back to that particular situation where we had this particular, the company tried to manipulate accordingly. But obviously, sir.
Yeah,
but
they
we
will
get
point out the benefits, and they will project more benefits, and the bad effects maybe, or the adverse effects maybe, underplayed. That is one, pinch of salt we should always have while analyzing the data. And investigator-initiated trials, the problem is that even though they are very much interested to dig into the details, but unfortunately, they don't have the muscle strength, so they will not be able to go into it. I mean that, they will not have so much of money to go in details to every aspect of what they think, because academicians, definitely they will think in a broader way and more pragmatic way. So, but they can only think, but they are not able to spend. So that is the thing which may affect the final outcome and final analysis. And critical analysis, definitely it helps both need to be taken with a pinch of salt, because academicians, even though they don't have any personal gain, unfortunately they are not able to do everything because of the constraints. Instrument constraints can be there, or reagent constraints will be there. And one more thing, academicians, when they are doing, so we should also take into account that they may not have the properly calibrated instruments. That is also one problem we have to keep in mind, because academic instruments, but when they do it GCP, and when they do it in an environment, especially sponsors, when they do it, they generally outsource to a well-reputed lab, and their result accuracy will be much more better. So that is one thing we'll have to keep that in mind also. Okay, so if no further, I think there was one comment here last.
So there is one question, I believe, what tool used for appraisal?
Yes.
CASP or Consort? So I believe where we had this Consort 2025, so we went with Consort 2025 because it was the latest one that was available. CASP is there. We can obviously go for CASP also, but it is there. But it was because we wanted just a recent one for an RCT, so we went for Consort. You could go for any one of them.
Yeah. So we have
the key features.
Yes, sir. Yes, sir. Please go ahead. Please go ahead.
I said you both have the key features. The key points are almost similar in both of them. They tend to focus on certain points. All of them have almost a similar parameter, but obviously consort was the latest one, so we went for that one.
Yeah, so
Yes, sir. Now,
I would like to appreciate Dr. Vijay Modgare, sir.
yes, sir.
He always is being the very senior person, and also, is a previous professor head of Nagpur Government Medical College, and
Government Medical College, Nagpur.
I appreciate him for joining these scientific sessions. I really appreciate you for like being part of all our programs. And thank you so much, sir, for joining. And if you would like to add some value in the future, now we welcome you also. So if no other comments are there, so I would like to now hand over the slides of this certificate. So just give me a minute. I will just project. Yeah. So, yeah, certificate. So please join me in appreciating the efforts of Dr. Prithpal Singh Makreja sir for taking this initiative, taking the opportunity to take our this opportunity and deliver this uh, uh, web journal club as the chairperson, and without your leadership, we would not have achieved this. Thank you so much for your
Thank you so much, sir.
enthusiasm and active participation. Then now I would
Thank you,
like
sir.
to
Thank you.
again appreciate Dr. Manu Arya. You really very nicely did the job of whatever the job that is assigned to you. For excellent presentation. Thank you so much. I'll be sending
Thank you,
these,
sir.
certificates. Yeah, it's a really good job. I appreciate you. Hope that these kind of discussions, what we have done today, will enlighten the knowledge, enlighten so many minds who are. We reached almost 65, 70 participants today online, and another 20 participants in YouTube. So it was very nice.
Yes.
We had a registrations around 170 registrations, and we can see the so much of enthusiasm. Yeah. But definitely, this recorded version will have many more views, and people will definitely like to learn from these kind of ventures. So thank you so much, both of you, from the Department of Pharmacology, TMMMC, Medical College, Moradabad, Uttar Pradesh. Thank you so much for making this possible.
Thank you so much, sir.
We
It was a
look
pleasure
forward
being
to.
with you.
Yes, sir. Please go ahead, sir.
So it was a pleasure being with you, and uh, it is really appreciable that you gave us this opportunity. Thank you so much for this opportunity.
Yes, sir. Thank you. Welcome.
Thank you so much,
And
sir.
we would like to have more in the future. Hope that like you will come up with some more of your some more presentations in the future. Maybe by encouraging more of of PTs from your department, and also I
Maybe, sir,
request.
we can
Yes,
do
sir.
that. We can do that, but I had a plan that maybe this was the article that we took up today was an article that was published in a reputed journal.
Yes,
It was indexed in almost all the indexing agencies. So obviously there was a lot of learning experience, but maybe I would definitely I would if all the people agree to it, I will definitely like to have one of the articles from a predatory journal also.
yes, sir. Yes, definitely. We will
And
definitely have a block.
then
Yes, sir.
we'll be able to see the difference
Yes, sir.
of what a good journal is
Yes.
and what are the article type of a good journal and what is the article type of a predatory journal, and then maybe we'll find out what is the way where we have to proceed forward.
Yes, sir. Yes, sir. Definitely, these kind of efforts will definitely help the, especially, like you may be knowing that many colleges are remotely placed. Many, pharmacology, not only MD pharmacology, there can be a pharmacist like M Pharma or PhD Pharma or many other, group, like even clinicians can also join, because science is same, and the method that need to be analyzed is same, and the same research is done in collaboration with the for other clinical departments and the non-clinical departments. So it's always very important to gain the knowledge through these opportunities, because these are, I feel that no, I'm very jealous of today's postgraduates, because they have these kind of opportunities. They get a lot of these kind of opportunities. When we
Yes, sir.
were PGs, we did not had any of this, even not even a single of these kind of opportunities. Whatever we used to do in the department only, that was only available. Otherwise, we don't have anything. So now I think everyone should take these opportunities available and learn from them, and then be a better person, because the world is becoming more and more competitive, and the
Yes,
best
sir.
person, is needed for this world. So we are in the process of, giving that kind of best person to this world. So please utilize, make yourself better, and what I say, there is no end for learning. Yeah, thank you so much, sir. With this,
Thank you so much, sir. Thank you so much.
I'd like to end today's program with a big thanks, and have a good day, good night. Enjoy your recorded version, and enjoy your next available part of your evening. Thank you. Good day.
Thank you so much, sir. Thank you.